Time's up. Mr. Chairman.
President Suho, you can start, yeah.
Yeah. Good morning. Good afternoon. Welcome to the APSC Crowd Forum for Cardiovascular Disease series. Today we have a unique topics about the female ischemic heart disease, the diagnosis, the treatment, and outcomes. So this compare with men, women have a unique phenotype of ischemic heart disease, including more non-obstructive plaque, more plaque erosion with thrombosis, more epicardial and microvascular dysfunction, more ischemic or myocardial infarction with non-obstructive coronary disease, and more heart failure with a preserved ejection fraction. In specific webinar today, we learn in depth with anatomy, anatomical, and functional test assessment in women with a chest pain, the when and how of coronary microvascular dysfunction, study in INOCA syndrome, the spontaneous coronary dissection in acute coronary syndrome in women, and finally, the strategy to improve the critical short-term or specific the 30-day survival in women with the non-ST and ST erosion myocardial infarction. I myself, Dr. Supotsi Mahashota from Thailand, President of the Heart Association of Thailand under the royal patronage of Her Majesty the King, will be chairperson today. And with me, we have Dr. Writing Chang's Associate Professor, Department of Medical Medicine, National Sun Yat-sen University, Taiwan. So she will be our co-chair today. That's next slide. Yeah, this is the disclaimer. Yeah. And let's get started with the first speaker, Dr. Shaisri Wallapakon. He's an interventionist, interventional cardiologist in my hospital. Yeah, he's our colleague, come from King Chulalongkorn Memorial Hospital. Today, he will talk about the anatomical and or functional state assessment in women with stable chest pain, differential approach to low coronary risk.
Can you see my screen?
Yes. Okay.
All right. Okay. Thank you for kind introduction and good morning, everyone. My name is Shaisri Wallapakon from King Chulalongkorn Memorial Hospital. Today, my talk is about women and ischemic heart disease, and I will focus on anatomical and functional test. So, as I am the first speaker, I would like to give you some introduction about the difference between men and women. So, someone said that men are stupid and women are crazy. But I am not the one who said this. Someone said that. But if you know the reason why, you might feel that this is somewhat true. So George Carlin is the one who said that. He's one of the most famous actor, one of the most famous comedian and author. He said, here's all you have to know about men and women. Women are crazy, men are stupid, and the main reason women are crazy is that men are stupid. So today, if I say something wrong, if I say something stupid, please forgive me because that's our nature, that's men's nature. Okay, let's move to our topic about ischemic heart disease and women. This is a survey which was done by Women Health Organization. They asked the female participants what are their concerns about their health. And can you make a guess which one is the ischemic heart disease? It is in number one of their concern. Actually, it is not. So the number one of health concern of women is not the ischemic heart disease. It's about their weight. So women always concerned about their weight, and followed by cancer, mental health, menopause, and chronic pain. So no one concerned about ischemic heart disease. So the same survey done by the same organization, but this time they asked only the healthcare personnel, only the female healthcare personnel. What are their concerns about the women's health? And again, ischemic heart disease, not even the one in the top 5. The first one is about the mental health, followed by menopause, and followed by, again, weight, then breast cancer and fertility. So no one, even healthcare personnel, concerned about ischemic heart disease in female. But if you look at the World Health Organization analysis about the top 10 causes of death in women, we can see that ischemic heart disease was ranked in number 1 of causes of death in women. For globally, and even us, the Southeast Asian. So we have a very high burden disease, high mortality, but no one concerns about that except us, except cardiologists. But even we do concern about the ischemic heart disease in women, but we don't know much because you know that most of the cardiovascular clinical trials, they enroll much more men than women, especially for the ischemic heart disease, both acute and chronic coronary syndrome. They enroll much more men than women. So we still have underrepresentation of women in most cardiovascular trials. So we don't know much. So we have a high burden disease, no one concerned about it, and we do not have a lot of information. And then I will move to my main talk about the diagnostic test. So according to ESC guideline 2019, if we encounter a patient who come in with the symptom of chest pain, chest discomfort, dyspnea, etc., then we go to this chart. We look at his or her gender, we look at his or her age, and we look at his or her symptom. Is it typical angina, atypical angina, or non-anginal chest pain? The typical angina need to meet all of these following criteria. The first one is constricting discomfort in the front of the chest, or in the neck, jaw, shoulder, or arm, which is precipitated by physical exertion and relieved by rest or night rest within 5 minutes. And for atypical angina, it needs to meet only 2 criteria. And for non-anginal chest pain, it needs to meet only 1 or none of these criteria. And then we will get a number, which is the pretest probability, or PTP. This number represents how high of the possibility that the patient really have the CAD. And after we get the PTP, or pretest probability, then we will look for another factors, such as if the patient have hypertension, diabetes, dyslipidemia, history of smoking, or LV dysfunction, etc. This kind of patient will have higher likelihood to have CAD than the one who doesn't have these factors. And the clinical likelihood will guide us to the test, what test we should be considered. if the clinical likelihood is high or intermediate to high, we will consider the non-invasive stress test. But if the clinical likelihood is quite low, coronary CTA should be considered. And from this slide, you can see that each test has its own accuracy. For example, for the coronary CTA, it has very high negative predictive value or NPV. So it does a very, very good job in ruling out the CAD if the test is negative. And for the MRI, the positive predictive value and the negative predictive value is quite high. So it does good job in both ruling in and ruling out the CAD. But for the stress ECG, which we still use quite a lot, you can see that in terms of accuracy, it might be not a very good test. But however, I think it's still useful in some situations, like if you have a patient with low clinical likelihood and the stress ECG is clearly negative, you can still rule out the CAD, but you have to choose the patient very carefully. So that is the guideline from the ESC, and that guideline is for both men and women. So do we have any specific recommendations or any specific concern for women? Actually, we do. For the exercise ECG, you can see from the table that the sensitivity, specificity, and positive value of the exercise ECG in women are lower than in men. For the sensitivity for women is 61%, for men is 72%, for the specificity is 70%, for men is 77%. And for the positive value for women is less than 50%, and for men is 77%. However, for the negative predictive value is similar, 28% for women and 81% for men. So if we have a female patient who have quite low clinical likelihood and the exercise ECG is negative, yes, we can rule out the CAD. And to gain more accuracy from the exercise ECG, we have to put all of this together. Not only the ST segment changes, but we have to consider the exercise capacity, the heart rate recovery, the Duke Treadmill score, and the blood pressure response. So that's the exercise ECG for women. And for the other tests, stress echo, PET scan, MRI, or CTA, both all of them have quite high sensitivity and specificity. So which one should be used for which kind of patient? Because they are quite similar in terms of accuracy. So not only the accuracy that we should concern, we also should concern about the safety as well, which I mean the radiation. So for patients, for female patients with low clinical likelihood, we can consider the exercise ECG is easy to use without without the radiation. And for those who have intermediate to high clinical likelihood, especially for young female patients or premenopausal female patients, we should consider the test without the radiation, such as the stress echo or the MRI. But if the stress echo or the MRI are not available, you might consider the stress MPI or low dose CTA, because both of them have quite low radiation. Both of them can be the alternative test if you don't have the stress echo or the MRI. And this is the consensus from Circulation 2014 about the female patients who came with the symptom which we suspect the ischemic heart disease. We start by the clinical livelihood. If the clinical livelihood is quite low to intermediate, and there is no resting ST segment changes on the resting ECG, we start by exercise test. And if the test is negative, we can rule out the CAD. But if the test is positive, this consensus guide to consider for the imaging test. But for me personally, if you have a female patients who have quite low clinical livelihood and the test is clearly positive, like diffuse deep ST depression with clearly symptomatic, clearly typical chest pain during the test, I don't think we need another non-invasive test if the patient have severe symptom despite of the medication. I think we can consider the angiogram. And for the patients who have intermediate to high clinical livelihood, we should consider about the imaging test, maybe stress imaging or the CTA, but do not forget to concern about the radiation. If the patient is quite young, premenopausal, we should consider the test without the radiation like stress echo or the MRI. And after you get the diagnosis, no matter of what test you have done, you should assess the risk of the patient, the risk to develop the cardiac event. For example, if the patient have more than 10% of area of ischemia, or if the stress echo show 3 or more segments with stress-induced hypokinesia, or maybe 2 or more segments with stress perfusion defect, this kind of patient will be classified as high-risk patient, and they will benefit from revascularization. So the next step is the angiogram. And last but not least, about the FFR, the fractional flow reserve. We all know that FFR is the current standard of care, and it is the class 1 recommendation for the patient with borderline stenosis, and class 2A as a FFR guided PCI, especially for the patients with multiple disease. So is there any difference between men and women in terms of FFR? This is the sub-study from FAME. The investigator, they compare the outcomes between men and women. And you can see that at the same severity of angiographic stenosis, female patients tend to have less functionally significant lesion. If the stenosis is around 50 to 70, you can see that only 20% of female patients have FFR less than 0.80, which means nearly 80% can avoid unnecessary PCI. For male, with 50 to 70% stenosis, about 40% of male have FFR less than 0.8, and about 60% of them can avoid unnecessary PCI. Same as for 70 to 90% stenosis, about 30% of female patients have FFR less than 0.8. That means about 30% of them can avoid unnecessary PCI. So I think FFR is strongly recommended for female patients with borderline lesion, because we can avoid a lot of unnecessary revascularization. And the clinical outcomes are the same. FFR guided PCI is equally beneficial in women as it is in men. So this is my last slide. Women and men are different, as I said before. And for the ischemic heart disease in women, it is a very high burden disease, high mortality. less concern, and we still lack of information. For the diagnostic test, it depends on the clinical likelihood. If the clinical likelihood is quite low, and there is no ST segment changes on the resting ECG, we can consider the exercise ECG. And if the test is negative, we can rule out the CAD. And if the clinical likelihood is intermediate to high, we should consider for the non-invasive imaging, maybe stress test, maybe the CTA, but do not forget to concern about the radiation. If the patient is quite young, we should consider the test without radiation or with very low radiation. And last but not least, for the borderline lesion, FMRI is strongly recommended for female because we can avoid unnecessary PCI. Thank you.
Thank you very much, Dr. Chasidi. Very excellent talk. Because of the time, I have for you only one question because of time. Do you think that why do you think that the women concerned less about the heart disease?
I think maybe both maybe patients and healthcare, we might feel that men have higher risk than women. So we do concern about ischemic heart disease in men more than women. So I think we have to change that women can also have ischemic heart disease, and some of them have quite severe disease as well. We have to detect quite early to treat them well before they get the severe disease. I think we have to change that concept that women has less likely to have CAD.
Yeah. That is the important point. Yeah. Okay. So I think we have to move to the second speaker. Yeah. Dr. Satoshi Moki. He's an assistant professor from Department of Cardiology, Hamamatsu University School of Medicine, Shizuoka, Japan. Yeah. He will address about the topic of the critical role of coronary microvascular dysfunction assessment in women with the INOCA and MINOCA, why, when, and how. Please, Dr. Moki.
Thank you, Dr. Chairman. I'd like to share my slide. Can you show my slide?
Yes.
Yes.
Okay, thank you.
Okay. Yeah.
Thank you,
Okay.
Chair.
Yeah. Go ahead.
Can you hear me? Okay.
Yes.
This is my great honor to have present our educational course, and my topic is INOCA and MINOCA. And especially is sex difference, and why and when and how to measure the CMD. As you know, ischemic heart disease were divided two groups for phase, chronic and acute. As you know, chronic phase is divided two groups, obstructive CAD. This is a classical CCS. And now today is my topic to STEMI or non-STEMI. And MI is divided to classical MI, MI-CAD, CAD, and MINOCA. Today's my topic is INOCA and MINOCA. Firstly, I explained INOCA. INOCA is ischemia with non-obstructive coronary arteries. This is the definition. The patient has a stable and chronic chest pain. And of course, patient can have an atypical symptom, like dyspnea on effort, not a pain, it's okay. And objective test finding of myocardial ischemia. Often it was non-invasive electrocardiogram at rest or stress, and ultrasonic and MRI and SPECT. and no flow-limiting physiological and functional stenosis on CAG or coronary CT angiogram, defined as organic stenosis of more than 50% or less than FFR 0.8. INOCA is diagnosed when all of the above are met. This includes this definition. Why INOCA is important? Because more often than you think, especially women, 20% of patients with typical angina don't have significant coronary arterial stenosis in this paper. And this, as you know, in famous ischemic trial, interest degree, 24% of patients who have significant ischemia, moderate or severe ischemia, proven by a nuclear test, don't have significant coronary stenosis. How to explain this? INOCA is very important for female chest pain. In ischemia trial sub-analysis, there is a significant ischemia was detected by MRI or SPECT or stress echo or ECG. However, coronary CT angiogram doesn't show significant stenosis. And these are INOCA. INOCA is associated with female sex and younger age and relatively less severe ischemia. And amazingly, women have more than four-folds odds of INOCA versus men on multiple rate analysis. Very important, I think. And maybe you can understand the practical diagnostic approach for INOCA. This is a publication from European Heart Journal. Firstly, we do coronary angiography, and you can recognize the not severe stenosis on coronary arteries. Then we do CMD test, FFR and CFR and IMR. I explained this procedure after that. Then if the IMR is less than 25, there is no coronary microvascular dysfunction. However, if IMR were more than 25, these patients have coronary microvascular dysfunctions. After, you may do also acetylcholine provocation test. And in Japan, can you hear me?
I cannot see your presentation. Yeah.
Sorry.
Yeah, we can see the slides now.
Okay, thank you.
Yeah. Can you make a okay? Okay.
Okay. And in Japan, we do acetylcholine provocation test first. Because, as you know, Asian people has more frequent vascular spasm. So we did acetylcholine provocation first. Then we did indexed nitrate. Then we measured the functional myocardial dysfunction test. So this is a controversial FMD measurement first or acetylcholine provocation first. In European Heart Journal, FMD measurement was first, is recommended. In Japan, we did acetylcholine provocation test below. First, we did a control shot. then insert temporary pacer to avoid bradycardia, then inject acetylcholine to right coronary artery first. Because if severe spasm will occur in left main or proximal LAD, there is a risk of vital collapse. So to RCA. First 20 microgram and then 50 microgram. If there is no spasm will occur, we switch to inject left coronary artery. In left coronary artery, we inject acetylcholine up to 100 microgram. After that, inject nitrates to both RCA and LCA. And in Japan, we always use acetylcholine to avoid rate adverse event using another spasm drugs. This is a typical case acetylcholine provocation test. This is a control. Maybe you can see a spastic in left coronary artery. After acetylcholine inject, there is a very tight stenosis was seen on mid-LAD. After nitrate, the stenosis will improved. This is an electrocardiogram during acetylcholine injected. In Japanese guideline, acetylcholine provocation test positive sign is below. More than stenosis, stenosis is more than 90%, and ischemic ECG change and patient symptom. Then I will explain CMD measurement. I don't know, you can use a CMD measurement in each country and every institution. In Japan, there is not so many institutions can measure CMD. Fortunately, we can measure this CMD. And we have to prepare this soft color flow, and maybe you can get a pressure wire. But only Abbott pressure wire is suitable for this system. When room temperature saline is injected into the coronary artery, the pressure wire, guide wire detects the temperature change in saline as it passes through proximal distal sensors. Coronary blood flow is estimated based on the time it takes saline to pass between the proximal and distal sensors. Pressure wire has not pressure sensor, but also thermosensors. So inject the saline, the temperature is changed like this. That time it takes for saline to pass between 2 points is recorded as a mean transit time. This is a mean transit time. So how to measure the IMR and the CFR? We always do like this flow chart. Insert pressure guide wire into coronary artery. After that, we inject room temperature saline, maybe 1 or 2 cc within 1 second. Very quickly injection is important. And measurement is 3 times is needed. After that, we did hyperemia. We often use nicorangil for hyperemia. Of course, you can use adenosine. Then we did saline injection again, 1 or 2 cc 3 times within 1 second. Very quickly is important. Then we can get the result. This is a example of CMD measurement. We can get a lot of measurement component. We can also measure FFR, and this is a CFR. Less than 2.0 is important. And IMR. IMR is more than 25 is important. And this is a mean transit time. 0.29 seconds or something. And hyperemia is a shortening of mean transit time. I will show you some example. You can see quick injection for coronary artery like this. Only 1 or 2 cc. Then thermosensor indicates the temperature down. After 3 or 4 times injection with room temperature saline, we need hyperemia. It is a nicorangil. After nicorangil injection, same procedure is needed. Quick saline injection. Then some sensor is indicated like this. I think it doesn't take a lot of time. It is only 1 or 2 minutes to measure this, like this. After measurement of CMT before I explained, we can devise a lot of phenotype of INOCA. If there is a symptom of myocardial ischemia and also absence of obstructive CAD and evidence of impaired coronary myovascular function, there is a possibility of myovascular angina. Okay, next I explain MINOCA. Myocardial infarction with non-obstructive coronary artery is a MINOCA. Same as INOCA, MINOCA need acute MI criteria and less than 50% stenosis on angiography and no clinical overt cause for presentations. MINOCA is it's a temporary diagnosis. If troponin is positive and no coronary significant stenosis and acute phase, it will divide MINOCA mimickers and true MINOCA. And MINOCA mimickers include myocarditis and Takotsubo syndrome and ischemic cardiomyopathy. And MINOCA is divided to maybe 3 or 4 groups. Epicardial coronary vasospasm and thromboembolism and SCAD and coronary myovascular dysfunction. So why CMD measurement is important for MINOCA? Because if the patient have coronary myovascular dysfunction, renin-angiotensin ACE inhibitor or statin is good for beta blocker is better for relief symptom. However, if the patient have a coronary vasospasm, beta blocker is worse drugs. So we have to diagnose there is a possibility. Is there a possibility of spasm or CMD? And this is the epidemiology of MINOCA, and depends on reports. Less than a few to less than 10% of all AMIs. 1 year mortality is around 5%, and patient characteristic have more younger and more healthy, more less smoker, less diabetes, less hypertension than MI-CAD, classical MI. And this is an important point for female. As you know, female proportion of MI-CAD is less than 50%. Male is more frequent than female in MI-CAD. However, in this report, MINOCA is over 70% in female. So if we encounter the chest pain of female chest pain, we have to consider the possibility of MINOCA. The Berg study of young patient with acute MI reported women were 5 times more likely to have MINOCA than aged matched men. So it is important for consider the MINOCA. This is a practical diagnostic approach for MINOCA. And in MINOCA is imaging is more important, like OCT for coronary plaque assessment, and cardiac myocardial CMR is also important. Then this is a final slide for me for my presentation. And why we have to consider the difference of physical assessment between men and women, because in previous presentation, women has higher CFFR compared with men, and same angiography like that, lower CFR compared with men in female, and higher CFR compared with women. So to understand the score of CFR is important, especially in women. It's the same slide in previous doctors. Why FFR is higher in women than men? Because fewer higher risk plaques in women and smaller myocardial mass and smaller coronary vessel and less plaque burden in female patients. That's why CFR and FFR is different between men and women. So we have to know these difference. Thank you for your attention.
Thank you very much, Dr. Moki, for your excellent talk. First of all, I would like to apologize, Dr. Chaisiri, for the Q&A session because of it's my fault that he still have some time for the Q&A question. Maybe he will join with question session Q&A question with Dr. Moki. Yeah. Yeah. I think is there any question?
Professor, may I?
Yeah. Dr.
Yeah,
Chan?
actually. Yeah, thank you so much for this excellent talk from Dr. Moji, and I really enjoyed. And actually, I have one question because we talk a lot about the coronary microcirculation dysfunctions and how the roles in MINOCA and INOCA. But I'm kind of curious that is any kind of recommended treatment or how to improve the microcirculations, especially in women? Thank you.
Thank you for a good questions. There is not so specific drugs for women, because we have only a few drugs for relief the symptom for MINOCA. So we have to research another drugs for relief symptoms. Thank you for good questions.
Thank you.
May I have some question for you, Dr. Moki? Do you do acetylcholine test as a routine in suspect case of INOCA?
Yes, routinely.
Yeah, routinely. Yeah, very interesting. Yeah, I have done for a long time ago when I be a fellow in Netherlands. When I come back to Thailand, I never done again. Yeah, this is very interesting. Yeah.
Yeah, it takes a few minutes or 10 minutes. So
Yeah.
interventional cardiologist doesn't like to do acetylcholine provocation test. However, it's important to understand the patient's symptom.
Yeah. Yeah. Okay.
Thank you.
May I have one question for Dr. Moki?
Yes.
When you do the acetylcholine test, did you find any severe spasm that caused the VT or VF?
VF? Ventral
Yeah.
complication?
Yeah. Did you find any any
Complication,
spasm?
yeah.
A complication, yes, of
Yeah.
course. Less than 1 or 3% complication is occur, like arrhythmia and shock and ST elevation. However, if we inject the nitrate to coronary artery, almost case the coronary spasm is released. So I strongly recommend to use acetylcholine. Yeah.
Hi, thank you
Thank
for
you.
your interesting talk. We recently started using acetylcholine, and it's really helpful because, women present a lot with chest pain and they don't have an answer, and it really helps them in terms of just knowing why they have the chest pain. But we always start with the left. What's interesting, you put a temporary wire in first, and you start with the RCA. Why do you do that again? I'm sorry.
Because I explained in my presentation, if the spasm occurs in left main trunk or proximal LAD, vital collapse will occur. So firstly, I try to inject RCA first. Of course, you need a temporary pacing due to avoid bradycardia.
Thank you.
Do you concern about the CFR? Because I have some experience long time ago. Yeah, because of at that time it's not reproducible for the CFR. When we inject the adenosine, sometimes it's high, sometimes it's low, particularly after stenting. Do you have any problem or do you have any comment? Yeah.
Yeah, CMR is a very useful tool for detect the mechanism symptom. So if I can't understand or if I can't understand the mechanism of patient symptom, like after a nice CMD measurement and acetylcholine provocation test, we will do CMR every patient.
And it's reproducible every time when you do the CMR. Because of I concerned about the accuracy or something. Yeah. Do you have any problem?
I don't have a lot of case, but maybe your opinion is very important. Yeah.
Yeah. Okay. For Dr. Chaisri, yeah. Okay. You have any comment?
I have one more. For the patient, like if the patient is really big and the symptom is likely to be spasm, do you increase the dose of acetyl?
Yeah, very important questions. But in advanced institutions, in RCA, the specification 50 microgram inject is available. Of course, 200 microgram to left coronary artery is also available in some centers in Japan.
Thank you.
Maybe I ask Dr. Chaisri about the calcium score in women. Do you recommend to test, or when do you have to test for the calcium score?
I think for the calcium score, it might be useful only in asymptomatic patient, just to classify them that do we need to increase the dose of statin? Do we need to control their risk factors? But if a patient with symptom of chest pain, I do not recommend the calcium score. I think we should do maybe the stress test or either CTA, because the calcium score doesn't help much in patient with symptomatic or in patient with suspected of CAD. I think calcium score just useful to for the classification of risk of the patient without the symptom.
Yes, but now this is like a routine regular checkup. Most of some doctors use the calcium score is one of the laboratory checkup. And what do you think that is okay or should be how how to manage.
I don't think we should do that routinely, but I may use that first of all, that patient need to be asymptomatic, no chest pain at all. And I might use in the patient that I classify him or her as an intermediate risk, like they might have hypertension, dyslipidemia, diabetes, maybe history of family history of heart disease, and they would like to know how high of the risk that they have. That kind of patient, I might use the calcium score, but not routinely.
Yeah, thank you. Is there any comment, Dr. Chan, about the calcium score in your country?
Actually, I kind of agree with what the first speakers recommended, because I think the calcium score usually we can quantify and we use do the like a risk segmentation in patient with like a moderate or a lower risk. But if the patient still already have the significant high risk, or they are still have like a typical chest pain, I think stress tests will be the ones that we have more information we can get. Yeah.
Yeah. So sometimes in private sector in Thailand, they use the calcium score as an indicator for coronary angiogram. Sometimes it's happened. Yeah. Okay. Okay. So we move to the next topic. Yeah.
Okay,
Maybe
great.
Dr. Chance will introduce.
Yes.
Yeah.
Thank you so much. And today is my honor to introduce the next speaker, and Dr. Maria Heger Maria. And she's the director of the Heart and the Vascular Institute in the Peturo Healthcare Medical Center in Philippines. And she's also the medical director. And today, after we talk about the MINOCA and the INOCAs in women, I think the next one will be another important issue about Takotsubo. So today, her topic is the appraisal and the treatment of Takotsubo syndromes in women versus men, and what is the distinct features and the considered outcomes. And so, please, Dr. Maria.
Can you see my screen?
Yes, it's clear.
Yeah.
Right. Okay. So today, everyone, I'd like to thank the organizing committee, Madam Chair and Madam Chairwoman. Thank you for that introduction. Today, my task is to talk about the appraisal and treatment of Takotsubo syndrome in women versus men, to just show the distinct features and contrasted outcomes. So I have nothing to disclose that will be in conflict with today's presentation. And so today we will appraise the differences in the features and outcomes of Takotsubo syndrome between men and women. And we shall also try to discuss the management of Takotsubo syndrome in men and women. As a springboard, please allow me to present two cases. So this is a lady here on the left-hand side of your screen, and a gentleman on the right-hand side of your screen. The lady is HM. She's a 74-year-old female complaining of chest pains followed by shortness of breath while attending a wake. So the death of the husband, actually. She's receiving medications for hypertension, impaired glucose tolerance, and dyslipidemia. She's overweight, and initially the troponin was normal but increased subsequently on monitoring to 0.56. So this is 10 times higher compared to the baseline. While the gentleman, DM, is a 68-year-old man complaining of difficulty of breathing, not really chest discomfort, more of difficulty of breathing. It's been treated as COPD and exacerbation with respiratory tract infection. Also receiving medications for hypertension, dyslipidemia, mildly overweight. Same with HM. The troponin was initially normal and increased subsequently to 10 times higher at 0.6 nanograms per ml. The baseline EKG of HM, the lady, showed sinus tachycardia with some ST changes. Some ST changes in V2 and V3. The baseline EKG of DM also showed this distinct ST elevation in V2 with sparing of the V1, both in HM and DM. The follow-up EKG of HM now shows distinct evolution of the SCT changes in V2, V3, V4, V5, and V6, 1 and AVL, with prolongation of the QT. And this is remarkably more evident in the case of DM, the gentleman. The echo of HM showed wall motion abnormality, hypokinesis here. Oops, I hope it shows. Some apical ballooning, wall motion abnormality, hypokinesis at the apex, and same with DM. I hope you can see the video right there. Okay, and the LVEF of HM is slightly elevated compared to DM. So 40 for DM and EF of HM is 43%. They were both sent to coronary angiogram because they presented with progressing chest pains, elevation in troponin, and to attempt to try to revascularize, they were sent to cath lab. And both did not show significant epicardial coronary stenosis in HM's angiogram and in DM's angiogram. And so these patients, the recommendation, if we're looking at a patient with a working diagnosis of MINOCA, and Dr. Satoshi talked about this earlier, that we must be able to differentiate the specific non-MINOCA cause of the myocardial injury, and that is via a cardiac MRI, to be able to differentiate the ischemic pattern of myocardial injury, whether it's non-ST elevation myocardial infarction or MINOCA, or ST elevation MI, a non-ischemic pattern which can be found in patients with Takotsubo and other cardiomyopathies and myocarditis. So HM was actually sent to cardiac MRI, and we see the apical ballooning here with no LGE, corresponding LGE, or signifying contrast enhancement. So the fourth chamber here on the bottom line, bottom figure, showing again the apical ballooning, but no LGE. And recently, we have this technique that looks at possibility of myocardial edema in patients presenting with myocardial injury. And we see that the apex or the apical segments actually has relatively higher T2 signal, and this grayish enhancement at the apical region where there is wall motion abnormality over here. I hope you can see it, right? With no LGE. And this increase in the T2 signal and T2 map actually corresponds in histopath and those who did not survive Takotsubo cardiomyopathy as interstitial infiltrates of lymphocytes, leukocytes, and macrophages, and contraction band or without myocyte necrosis. T1 will also be elevated. And here, in the region where there is wall motion abnormality, you can see that the T1 signal, as well as the computed extracellular volume, is elevated, signifying myocardial injury in these patients with Takotsubo despite absence of late gadolinium enhancement. So can we differentiate? Is there a way we can differentiate these patients with Takotsubo, transmural MI, MINOCA, and myocarditis, patients presenting with normal angiogram and elevated troponin? And we see that in patients with Takotsubo, there is no LGE. But those patients with acute myocardial infarction from proximal LAD obstruction, for example, will have the same wall motion abnormality, but on late gadolinium enhancement will show transmural enhancement of the area subserved by the proximal left anterior descending artery. MINOCA will not show significant stenosis, but might have some microvascular dysfunction or small vessel disease, and they will sometimes show subendocardial late gadolinium enhancement. Myocarditis, on the other hand, may or may not show motion abnormality. The angiogram will usually be normal, and the LGE will show this mid-wall and subepicardial late gadolinium enhancement in a patchy manner. And in the meta-analysis of these patients, about 1,500 of them, 26 studies, 18% of patients presenting with myocardial infarction, non-obstructive coronary arteries actually had Takotsubo cardiomyopathy. Majority still are MINOCA and myocarditis, more predominantly myocarditis. The rest are other cardiomyopathies, and 26% no established cause, making us realize that maybe we should go back to the coronary artery analysis of this subset of patients. So just before discharge, both of these patients were managed well. And just before discharge, we see that there's actually resolution of the wall motion abnormality just before the discharge. You see that we lose already that apical ballooning type of configuration, and we see this very perky apical segments of the LV, including the apex. And so both DM and HM actually satisfied the diagnosis that was diagnostic criteria by the INTERTAC Takotsubo diagnostic criteria, showing transient left ventricular dysfunction, hypokinesia or akinesia, presenting as apical ballooning. RV may sometimes be involved, but in this case, it was not involved. For our case, the case of HM was actually triggered by an emotional predisposition, while DM was a physical trigger, and we did not see any presence of significant coronary artery disease, but we saw evolution of the STT changes from ST segment elevation to depression, and then followed by T wave inversion and QT prolongation. So as a review, Takotsubo cardiomyopathy has been postulated to be due to excessive catecholamine or sympathetic stimulation. And they found that norepinephrine levels are actually elevated in 75% of the studies. And plasma catecholamines are significantly higher, 2 times more than cases of myocardial infarction. And this excess in catecholamine actually predisposed patients to microvascular spasm or dysfunction, leading them to repetitive myocardial stunning or direct myocardial toxicity as a cause of Takotsubo. Okay, so Takotsubo cardiomyopathy is not rare. It is estimated to represent approximately 1 to 3% of all myocardial infarctions, but 5 to 6 of female patients presenting with suspected STEMI actually had Takotsubo cardiomyopathy. There is a predominance of this occurring in women, 80 to 90% in women compared to 10 to 20% in men. And we see here in this graph, there's a distinct predominance of the occurrence of Takotsubo in men. So in the USA data and the INTERACT registry, which includes the Europeans, the ratio is about 1:9, or 10% in men and 90% in women. And this Asian data, which was done by the Japanese Dr. Murakami, actually showed that there is more male afflicted with Takotsubo cardiomyopathy, with 22% and 77% in women. Our initial findings back home actually show that there is a 25%. This is still a small population, as we just did it as soon as the invitation was actually sent to our country. So the initial findings in 2 centers with PCI capable and CMR capable showed 25% in men and 75% in female, almost similar to what was seen in Japan. All right. Is there a reported contrasting features and clinical presentation between male and female reported in a larger cohort of patients? So we are looking at this registry, which is the GIST registry, German, Italian, Spanish, Takotsubo registry, which included 2,492. This is a very busy slide, but I'll just summarizing it for you now. And in here, there were 11% male in the population in this cohort, and there is a significant age difference. The male were usually younger compared to female, and there's higher prevalence of comorbid illnesses in male. More diabetes, so this is 25% compared to 19%. Pulmonary disease, 21% compared to 15%. Malignancies, 25% versus 13%. And smoking habit, 33% in men. And the clinical presentation, which we saw both in the case of HM and DM, there's more frequent dyspnea in male, less often chest pains, and there's more physical trigger. Again, we saw this in the case of HM and DM, and less emotional trigger, more emotional trigger in women. Okay, what about comorbidities? So pulmonary disease, looking at the whole cohort, pulmonary disease, malignancies is more prevalent among male. But when we look at the match cohort, so this is age match and comorbid match analysis, we see that there's no significant difference. But the in-hospital complication is rather persistently or consistently significant more in male cardiogenic shock and in-hospital mortality over here, which is more predominant in male. All right. So what is the potential cause of the difference in the manifestation? They say that there's stronger gene expression of extracellular matrix in women, and there's higher ECM integrin interactions. And they saw this in histopathology as a broader necrosis area with infiltration in men and fewer necrotic areas without lymphocytic infiltration observed in women. Okay, so what about EKG? Is there a difference in how they manifest? There's no significant difference in the ECG manifestations, no significant difference in the apical ballooning pattern in both men and women. So we saw this in HM and DM. But the LVEF, again, similar to our case today, is the LVEF is usually significantly lower in men, so 38% versus 40%. At about in-hospital mortality. So complications and outcomes in Takotsubo frequently is comprised of acute heart failure in 12 to 45%, outflow obstruction in very perky or dynamic base of the LV in 10 to 25%, MR, which goes hand in hand with LVOT obstruction, and cardiogenic shock because of the lowering of the stroke volume. AFib is moderately found, 5 to 15%, LV thrombus, cardiac arrest, and AV block. Rarely, some tachyarrhythmia, bradyarrhythmia, and torsade. So what parameters may predict adverse in-hospital outcome? Physical trigger, which usually happens in men, acute neurologic or psychiatric diseases, initial troponin, 10 times upper reference limit. We saw this in our cases today, and admission LVF of less than 45%. Male gender is a predictor of outcome, giving us some idea that we should probably look at this subset of patients a little bit more closer. So up to 3-fold increased rate of death and major adverse cardiovascular events in men, and more often has an underlying critical illness. So these are physical problems like malignancy and COPD and pneumonia. So the in-hospital mortality, 60 days mortality, is higher in men. So this is the red line compared to women. And the long-term mortality, looking at the entire cohort, the whole cohort, higher mortality in men. So the age match analysis, which is this, still shows in hospital mortality higher in males with Takotsubo syndrome. But among patients who already had recovered, the outcome is not significantly different between male and female. So we just need to get them out of the acute phase to be able to mitigate risks for this subset of patients in both male and female gender. So the risk is not low, 5 to 6% estimated mortality rate per patient per year, both in men and women, higher among males. Major adverse cardiovascular event, higher in male, 9.9% in the whole population. But the recurrence rate of Takotsubo is not significantly different, not also low at 1.8% per year. For the treatment, there's no guidelines regarding Takotsubo because there's no randomized clinical trial really looking at this subset of patients. And so these are recommendations based on the experience of those who wrote these recommendations. And so it is subclassified into acute heart failure treatment while in the hospital. This is very important because the in-hospital mortality really increases if we don't do well in this phase of their disease. So mild Takotsubo syndrome without signs of heart failure, ACE inhibitor or ARB, this was talked about earlier, and beta blocker. For those presenting with edema, still go ahead, the ACE inhibitor, beta blocker. Maybe avoid some diuretics. Admit in the intermediate care. Avoid adrenaline, noradrenaline, dopamine, milrinone, and isoproterenol. Those presenting with hypotension and cardiogenic shock admit at the intensive care unit, preferentially. And those presenting with LVOT obstruction, IV fluid, short-acting beta blocker, maybe an LVAD. Avoid diuretics and a vasodilator or afterload and preload and loader. Primary pump failure, consider levosimendan, we don't have it in the Philippines, LVAD or an ECMO. For the complications for arrhythmia, beta blocker, temporary RV pacing, so do not put a permanent pacer, a live test. For thromboembolism, give heparin or vitamin K antagonist and maybe a NOAC. Consider anticoagulation if the EF is less than or equal to 30%. And when you see that the LV apex is so large and there's a lot of stasis in the region. So on discharge, consider for 3 months or until regional wall motion abnormality recovers an ACE inhibitor, an ARB, and treatment of underlying disorders, especially among men. So their physical trigger must be addressed, such as COPD, malignancy, and other stuff. Consider aspirin and statin. And to avoid prevention, there's still a talk about maybe hormone replacement, but I think that we should put them on ACE inhibitor and ARB. So in summary, patients with Takotsubo, there is a prevalence of this illness or syndrome or myopathy, if you will, and among females at 80 to 90% in the overall cohort. And the clinical presentation differs. Women presents with chest pains, while men presents with difficulty of breathing. Emotional trigger is predominant for female, physical trigger predominant for male. There's more comorbid illness, so smoking, cancer, COPD in men. And the LVEF is usually a little bit lower in men, 38% versus 40% in women. In hospital complications and mortality is higher in men. And this is the driver of mortality in Takotsubo syndrome. And we need to look at this subset of patients really well. Long-term survival is not significantly different for as long as they have recovered. And the management, because we don't have any randomized clinical trial yet for this subset, is based on the manifestation and the tailored strategy. For the future direction, we still don't know why women are afflicted more with Takotsubo cardiomyopathy and whether we should actually differentiate the way we manage them. Will the outcome of this subset of patients differ? I'd like to thank you all for your kind attention.
Okay, thank you so much, Dr. Maria. I really appreciate your talk, especially the binary tables. This is beautiful. And also the comparison between the coronary angiography and also the cardiac MI and between different kinds of MINOCAs like obstructive coronary disease. This is very nice. And actually, I think because time is limited, but I still have 2 questions, if possible. The first one, actually, because you point out, I think it's very important that Takotsubo is not as benign as we thought. And also, possibly the woman will have better outcomes. And you raised the hypothesis because there's a extracellular matrix. And you think the estrogen, so like a sex hormone, could possibly play a role that's why the woman will have better outcomes?
I think it might have, especially when it becomes recurrent. I think that we can maybe introduce a low dose of hormone replacement therapy in this subset of patients. The predominance of women afflicted with Takotsubo is in the elderly population, and they say that it's because they lose the benefit of the estrogen. And I think that if it becomes recurrent, when they have it again, you accumulate the risk of this patient and potentially increasing their chance of having mortality. I think it's worth giving them a low dose hormone therapy. I think we need to study this therapeutic strategy in a large population.
Exactly. And the second question is, because you said that if the woman patient has like a diabetes or like the old age or less, the other risk factors, actually we can see also in the patient with her coronary microvascular dysfunction. So you think it's possible if a patient have MINOCA in women, there will be overlap between the different spectrum, like the ones also have like a microvascular dysfunction, and they have risk to have like a Takotsubo or the MINOCA disease.
Absolutely. I think there's no like this is specific or this is just for this subset of patients. I think the risk is higher in the elder population, those with comorbidities, because they already have a baseline underlying structural abnormality in the microvascular area of the coronary arteries. And so when they are exposed to a trigger, whether it is emotional or a physical, then it happens. Absolutely, I agree.
Great. Thank you so much. I'm wondering questions from panelists?
Yeah. Okay. You said I'm Dr. Spot here. Yeah. I would like to ask some question. Do you send all the patients for coronary angiogram in case of highly suspicious of Takotsubo? Or you just wait until
Yes.
the LV function recovery?
Yes, because most of the men and women who present with Takotsubo actually already have a baseline characteristic that is at risk for coronary artery disease. I think it's very important to eliminate the chance of significant epicardial disease, because we can right away decrease the risk of this patient. And so the goal is to send them to cath to be able to revascularize, so that if we don't see it, then we go back to the table. This is MINOCA. What is the cause of MINOCA as a working diagnosis? But I think because this is the more predominant disease, that we should eliminate it as soon as we have the opportunity, just to improve survival.
Okay. Yeah,
Yeah.
because sometimes they don't have any chest pain, and we identify the precipitating very clearly, and the LV function is very look like at Takotsubo, and the cardiac marker is not increased, not so much when compared with the occluded myocardial coronary infarction. Yeah.
Right. In our country, not all hospitals actually are PCI capable. And so sometimes we pray that it resolves in 5 days just before we discharge them and give them medications. And we are a little bit more comfortable if the echo resolves in some way. And we just say, maybe it's due to spasm, maybe it's MINOCA or Takotsubo.
Yeah. Anyhow, the diagnosis should be rule out the coronary first. Yeah.
Right.
Yeah. Okay.
Eliminate the risk and improve outcomes, I think, is the primary goal.
Great.
Okay.
Yeah, I'm wondering any other questions from the audience or from the panelists? Okay. Okay, if not, because the time is limited, and thank you so much, Dr. Mira, again. And I'm going to introduce the next speaker. And the next speaker is Dr. Jialing Lin, and she's the attending physician from the cardiologist department in National Cheng Kung University in Tainan, Taiwan. And today she's going to give us a talk about the appraisal and the management of another different kind of spectrums. This is from spontaneous coronary dissections in women with acute coronary syndromes. So we'll focus on the obstructive versus non-obstructive coronary disease in the different genders. So please, Dr. Lin.
Good afternoon. Is my voice clear?
Yes.
And my slide on full screen?
Yes, no problem.
Good afternoon again, and thanks for the chair's kind introduction. I'm Jialing Lin from National Cheng Kung University Hospital, Taiwan. It is my pleasure to share something about an emerging issue, spontaneous coronary dissection. It usually presents in women as acute coronary syndrome. The subtitle is obstructive versus non-obstructive lesion, but in the following talk, you'll see that is probably not the only thing to consider about this disease. So in the following 20 minutes, I will start with 2 cases. Then we'll go through some basic information about this disease, and then to the focus of today's talk, how to manage this condition. Finally, we'll visit the 2 cases again, see what we did, and reflect if we could do better, and summarize this talk. So first, let's see 2 cases we encountered just a few months ago. This lady, Y, is 50-year-old. She had no underlying disease. In one summer afternoon, she reported chest tightness with a compression-like sensation. She had a severe episode when climbing upstairs. Well, later that night, she visited a local hospital and was transferred to our hospital for elevation of cardiac enzyme. This is her ECG at the local hospital. And the ECG, when she arrived at our hospital, no specific ischemic change of the ECG, but with typical symptom and the elevation of cardiac enzyme, she received angiography following day. This right panel is the first set of image. To be honest, I don't really recognize the lesion at the first sight, but to film the second series, we saw a contrast staining here. So in this series, it seemed quite obvious that she had spontaneous coronary artery dissection. She was symptom-free during the exam. We'll stop here for this case and come back to her later. Let's see another case. Lady L, she is a case from my colleague. She's 60 years old, reported to have hypertension, a non-smoker. She had chest tightness with cold sweating after breakfast, and then she visited a local hospital and was transferred to our hospital immediately for STEMI. This is her ECG. Well, in my opinion, she had a borderline ST elevation over inferior region, and with persistent symptom and a relatively lower blood pressure than her baseline, she received immediate coronary angiography. This angiography showed a dominant posterior lateral artery from RCA and with a segment of near total occlusion. During the exam, the patient still reported chest tightness, nausea, and relative low blood pressure, about 90 millimeter mercury for systolic blood pressure, and her baseline is about 120. We'll stop here again. Now let's review something about spontaneous coronary artery dissection. I'll refer to as SCAD in the following speech. SCAD is a separation of the layers of an epicardial coronary artery wall by intramural hemorrhage. There may be an internal tear or not, and this injury is not associated with atherosclerosis, iatrogenic injury, or trauma, so it's spontaneous. The most popular pathophysiology of this phenomenon is called outside in disruption of traversing microvessel, that is a vessel outside this lumen. This microvessel rupture and produces intramural hemorrhage, and the hemorrhage separate the internal complex, and this hematoma then compress the true lumen of the vessel, causing stenotic-like lesion in angiography. But why this happens? Well, when you see a picture with so many words, it usually means we don't really know the answer. But the most popular theory is that there is some underlying condition leading to vessel vulnerability with an additional trigger. The dissection just happens. Overall, in acute coronary syndrome, SCAD is rare. But if we narrow the population down to younger female, SCAD became a more frequent cause of ACS. Among SCAD, most cases, 90% are women, and the mean age of presentation is about 50 years. So if you see a typical case of SCAD, it would be a middle-aged woman with few traditional cardiovascular risk factors. Male are extremely rare in SCAD. And in presentation and some associated disease of SCAD, there are also sexual differences, but I'm not going to detail. The presentation of SCAD is just like ACS. So like these two cases, they present with chest pain or other equivocal symptoms with elevated serial biomarkers and ECG finding consistent with ischemic. Probably the only hint is a different patient phenotype. A relative younger female with few traditional risk factors for cardiovascular disease seem less likely to suffer from ACS. So it's important to educate physicians to raise awareness when you encounter this group of patients. Before we go to diagnosis, I would like to highlight a special subgroup of this special disease, that is peripartum SCAD. Pregnancy-associated SCAD seem to be a more severe subtype. It usually with worse ejection fraction impairment and unstable clinical presentation like fatal arrhythmia, cardiogenic shock. So bear this group of patients in mind. The diagnosis of choice is coronary angiography, and SCAD usually to happen at middle to distal part of arteries. Left anterior descending artery is the most commonly involved. And when you do angiography, identify these features. These are high-risk features for the disease to deteriorate if with conservative management only. If you see multivessel involvement, a severe stenosis, say like more than 80% stenosis, and isolated intramural hematoma. So there's no release of this hematoma, so probably more risk. Let's go to details of some angiographic diagnosis. The first upper panel is a normal vessel, and type 1 SCAD present with a flap. So usually you would see a radiolucent plane on angiography. And type 4 SCAD is the extreme type with a complete occlusion of the vessel. That would present as STEMI. Type 2 is the most common type with long segments of narrowing on angiography. 2B is with a narrowing extent to the end of the vessel. Type 3 is the least type, but this focal stenosis look quite like atherosclerotic stenosis. So this is an atherosclerotic mimic. So you see like the type 3 SCAD, sometimes angiography alone is not enough for diagnosis. That is one of the situations you would like intravascular image. But in SCAD or suspicious cases of SCAD, these patients' vessels tend to be more tortuous. And as we mentioned, the lesion is usually at middle to distal part. So intervention bears more risk. Therefore, most recommendations suggest intravascular image for 2 conditions to clarify diagnosis or as guidance during percutaneous intervention. Available intravascular images are OCT and IVUS. Sometimes even with this intravascular image, coronary angiography is not just enough to make a diagnosis. In this condition, non-invasive image may help. Cardiac CT or MRI may serve to help differentiate the cause of ACS. CT may also be used later in the stage to assess if there is vessel healing. So if we made a diagnosis, what to do next? This is the most important part of today's talk, because these patients present like ACS, but the management is not really quite like ACS. During diagnosis, the acute phase, the goal of management is to restore or preserve myocardial perfusion and cardiac function. The nature of SCAD is that the majority of cases heal by conservative management within 30 days. So anticoagulation is reserved for specific indications, or you just see intraluminal thrombus in angiography. Thrombolysis is generally not recommended. For PCI in SCAD, there are more risks because when there is existing vascular injury, they are more likely to have more complication, such as your guide wire entering false lumen, creating further dissection or propagation of the existing hematoma, and the worst, to cause abrupt occlusion of the vessel. Second, as mentioned, the most common type of SCAD is long narrowing. So with long lesion, you possibly need multiple stents. Third is a later issue. We say that SCAD usually resolve in 1 month. So after resorption of the hematoma, there might be stent malposition, which is not good for the vessel outcome. So once again, manage this patient as conservative as possible. What about surgical intervention? Quite like PCI, surgical intervention for these cases had higher risk. than usual ACS because the injured vessel is more fragile. They are less likely to hold suture, so it's more likely to have some anastomotic complications. And another issue is like a PCI. Later, when the native vessel recover, due to competing flow, the bypass vessel is likely to fail. But in some conditions, some patients just need revascularization. So the point at the acute stage is to identify who need revascularization. We call this high-risk patient. And this high risk is could be assessed in two aspects. One from its anatomical feature. If there's proximal coronary occlusion, especially left main, or multiple vessel involvement, this is high-risk feature. And by clinical presentation, if the patient presents with unstable reason or unstable hemodynamic, you probably need to revascularize them. And third is if there's persistent symptom with other objective evidence of ongoing ischemia. So quite like our second case. This algorithm summarizes how to manage SCAD in acute phase. If this case are managed conservatively, please do let them stay in the hospital for 3 to 5 days for close monitor. Right after the acute stage, the medical therapy aims at to relieve symptoms and to prevent complication and recurrence of SCAD. If there is a certain indication, for example, with left ventricular dysfunction or post-stenting, then they should be managed as guideline directed. But if for conservative management, there's no consensus on the use of antiplatelet, although they do present like ACS. For the comorbidities, the most common is hypertension. So you have to control the patient's blood pressure well. To reduce the recurrence, only beta blockers showed benefit, but this is only demonstrated in a single study. For long-term management, I'm not going through all this list just to show you that there are so many things to consider to provide comprehensive care. There are a few things I do like to mention. One is this early post-SCAD chest pain. Because persistent chest pain may be a symptom of conservative management failure, but mostly these chest pain are non-ischemic. But to differentiate the etiology is sometimes challenging. So first of all, make sure you provide adequate medical therapy for symptom control. Then look for objective symptom of ischemia. And remember to avoid invasive angiography where possible. Another issue needs attention is that we say that possible this patient has some underlying condition to cause vessel vulnerability. So if possible, look for underlying systemic arteriopathy. And the most common associated disease is fibromuscular dysplasia. But there's no study showing long-term benefits of imaging for this EVA. But there are some vascular conditions that need to be treated. So it's important to identify this condition. Therefore, most recommendations do suggest to do an axial angiography from head to pelvis. Another commonly encountered issue is about physical activity. Because physical activity is a possible trigger of SCAD and do associate with a great part of cases. If we to give a high restrictive physical activity, that might not really be good because no activity at all is not good for patient health. But do remember to avoid extreme, like exhausting exercise or high strength exercise. Overall, the recommendation for physical activity should be individualized. So give tailored recommendation for your patient. This final slide of the management part is just to remind us that individualization of management is important. So now we'll go back to the two cases, see how we manage them. So the first case, Lady Y, she was symptom-free during the exam, so no further intervention was done for her. And her laboratory evaluation showed no more elevation of cardiac enzyme. For the risk factors of coronary disease, her blood sugar and cholesterol level seem quite acceptable for a 50-year-old. Her echocardiography later showed adequate aerovisystolic function with no regional wall motion abnormality. She was then discharged after 4 days of hospitalization and kept follow-up in my clinic. Now let's move to the difficult one. Lady L, who still had chest tightness, nausea, and relatively low blood pressure during exam. And as mentioned before, sometimes diagnosis is not quite easy. This hazy look like a total goody part. We actually could not make sure if this is a thrombus, like a usual atherosclerotic ACS, or there's something else. But there's some hint. Other parts of her vessel look quite smooth with no atherosclerosis at all. And the proximal part of this posterior lateral artery had quite long narrowing, so somewhat strange. Therefore, we did an intravascular image for her, and it showed a huge hematoma. As mentioned before, that intervention may cause more risk in this kind of patient. So in this patient, we use only cutting balloon to release this hematoma. After fenestration of IMH, her blood flow improved and she felt much better. But if you look carefully, that the distal parts of this vessel, it seems that it is narrower in the final image. So this image possibly just extend a little distally. As we say, the risk of PCI is high. But in this case, the benefits outweigh risk. Later, her evaluation showed highly elevation cardiac enzyme. Her global left ventricular function is fine, but with inferior hypokinesis compatible with her presentation as inferior MI. Interestingly, her metabolic profile looked quite similar, like the first case, not really high for a patient with ACS. After 6 days of hospitalization, she was discharged with no symptom. However, this lady lost follow-up after her first clinical visit. We don't really know why. To refer these 2 cases managed by 2 cardiologists, we do see that during the initial assessment, the intervention is reserved for patients with high risk. And this high risk should be considered in 2 aspects. One is anatomical feature. The high risk feature usually present as obstructive vessels. And also consider clinical presentation about the high risk feature. It usually presents as unstable hemodynamic or fatal arrhythmia. Second, I think to reflect on this case, we probably need more education, not just for the physician, but probably for the patient. This is a rather younger population, so we should provide them adequate information about this disease. They don't have common ACS, but their condition, this SCAD, do need to be followed in clinic. To summarize, bear SCAD in mind when dealing with ACS, especially in females with few risks of atherosclerosis. When you encounter this kind of patient, remember, initial non-invasive approach for stable patients. Do identify those who need revascularization. And third, we do need more research to provide more information and stronger recommendation, and continue education to enhance our awareness of this disease, like this lovely webinar. Thank you for your attention. Looking forward to discussion.
Okay, thank you, Jialing. That's really enjoy your talk, and also especially about the case. It's kind of interesting. And I think we got 5 minutes for the discussion, and I will start with the first one question. And I think that's because in your case, the coronary dissection location is like a PO branch of a right coronary artery. It's kind of spatial location. You think that the location of the coronary dissection will be specific in women or different in men? You think the RC will be the common site that we will have coronary dissection compared with the LAD?
I think possible because the cases are mostly female, not much male cases. So I did not see review about the difference involvement of vessel between the male and the female. But generally, as I review, the left side artery are more likely to have scad. Just these two cases we encounter happen at the right side. But mostly this does happen at a more middle to distal part. So like these two cases, at more distal parts of vessels.
Okay, great, thank you. And the other question is because the only one slide you mentioned about the peripartum and this kind of possibility will have the SCAD. But I think it's very difficult if the patient, if the female patient is still have pregnant. So it's kind of have to do the coronary angiography in this patient. I think, do you have any kind of suggestion if we have likelihood is a patient that have SCAD and still in the pregnancy, and is any kind of suggestion that we can do for the following diagnosis?
There's really no consensus about this part, but
Yes.
if you have high suspicion, and you should make sure that the mother is fine. So if the patient present as I say in the review that in peripartum SCAD, they tend to be a more serious subtype. So say if the patient is under unstable hemodynamic shock, then I think it does have to bear some risk, but to make sure if they have SCAD, possibly coronary angiography is still needed, indicated.
Yes. Okay, thank you. I'm wondering if the moderator or the other panelists will have questions for Dr. Lin.
I think it's very quite interesting. Yeah. Do you think that do we need angiogram to follow up the outcome, or you, as you mentioned that you try to avoid the angiogram?
Thank you for this good question. The reviews say that most cases just heal in 1 month. So usually no follow-up is recommended. This is only indicated when you suspect conservative treatment fail. So possibly when the patient still has symptom or other presentation that you suspect this SCAD even progressed, that's when you need follow-up angiography.
Can we use CT angiogram?
Yes, CT may be used to follow as a follow-up tool. But there's some limitation because these vessels are usually involved in a more distal part, so a narrow vessel. So I do read some reviews say that in the narrow vessel, more likely to be some artifacts. So sometimes CT is not enough to provide you a definite diagnosis.
And do you do the intravascular imaging all the case of SCAD? Or you
Not
just
all.
selected?
Selected, yes.
Okay. Yeah.
Great. Okay. So because I think if no other questions, because the time is limited, so we'll move to the last part. And I'm introduce the last speaker, and the speaker is the Dr. Seema Kinder-Noor, and she's an interventional cardiologist and also consultant and the program director of cardiologists in the Mayo Clinic, Abu Dhabi, UAE. And today her talk is about the reversal of short-term and long-term outcomes in women with STEMI and non-STEMI. So after we talk about different kinds of spectrums about non-obstructive and drug disease in the women, I think the most important thing is about the outcome. So let's welcome Dr. Noor.
Hi, thank you, everybody. Thank you very much, chairperson and co-chairperson. I'll just share my content. Can you see my screen?
Yes, but not the slides yet.
Can you
Okay,
see my
great.
slide?
Yes.
Okay. So a brief introduction. As you know, worldwide, ischemic heart disease is the leading cause of death in men and women. Yet for women, this is very unrecognized, and there's more emphasis on cancers. And as we learned from the first talk, also on weight from women and from the society. Outcomes following acute MI have improved in men and women over the last few decades, except mostly in women under the age of 55. Therefore, women may require special consideration in order to see continued improvements. A little bit about short-term outcome in women post-acute coronary syndrome. There is evidence regarding gender-specific differences in outcome following ACS, and the evidence is quite conflicting. We do know that women with ACS have been shown to be at high risk of bleeding related to their smaller body volume. Usually they're older when they're presenting, and their smaller blood vessels. Regarding PCI in STEMI, in terms of outcome, there was data from an Australian group that showed higher mortality, 30-day mortality in that group of women compared to men. Furthermore, female gender was identified as an independent predictor for in-hospital mortality in STEMI patients, in German patients, but not non-STEMI patients. There was a recent trial from the USA that found a high risk adjusted in-hospital mortality of female STEMI patients, whether they were treated with PCI or CABG. However, the same study did not show much in terms of gender difference in outcome in patients with a non-ST elevation MI treated with PCI in that period. But in non-STEMI patients, women patients treated with CABG, those patients had a higher mortality as compared to men. A higher adjusted risk of in-hospital mortality in female ACS patients treated with CABG was also described in several other studies with large samples. The finding was discussed as being due to, women do poorly with bypass surgery because of their smaller coronary vessels, increasing the likelihood of graft failure, and also that having longer treatment delays in women with ACS. However, there were contradicting studies that showed no significant gender-related differences in short-term survival. But overall, in terms of short-term outcome in ACS patients, in STEMI, it has been shown in the majority of studies that female patients do worse than men. And in non-STEMI patients, those that get bypass, females tend to do worse compared to men. So now let's look at the long-term outcome in women post-ACS. Really, there have been inconsistent results in terms of what the outcome is, depending on the gender of these patients. Several large studies showed no specific gender difference after adjusting for clinical risk factors in ACS patients treated with or without PCI or CABG. There was a more recent study that described the lower long-term ACS mortality risk in women compared to men. But at the same time, there was a Portuguese study, it's a single study that retrospectively looked at almost 900 STEMI patients, showed that women have a significantly higher 5-year mortality in female compared to men. As for ACS patients treated with CABG, higher all-cause long-term mortality has been observed worse in men compared to women for the long term. But again, some studies have shown mixed data with women doing worse in the long term. So we need more sort of evidence and more data, sex-specific research to look into the long-term outcome of females post-STEMI and non-STEMI. So why do we think the outcome is worse in women post-MI? Gender differences have been described when women present in the management and in the outcome of ACS patients. Women generally are older when they present, and they tend to be more fragile and have more comorbidities. Women tend to present later due to their atypical nature of symptoms. So in general, their first medical contact, first medical contact time is significantly longer when you compare it to men. When they do present on time, what tends to happen is that they don't get the required treatment. So they usually undergo a non-invasive strategy. And some studies have even shown that if the woman ends up getting an early invasive strategy, unfortunately, there's less chance of having the same treatment as a man, which is very strange. So say they both go to the cath lab, the woman will end up not getting a stent when a man will get a stent. This is what some studies have shown. So the last thing also is the women, when they're discharged, they're not discharged on the same dose of evidence-based medicines as men. So statin therapy, beta blockers, often they're not discharged on the similar doses. And it may be because women cannot tolerate higher doses, I don't know. Other factors that can contribute, that we think may contribute to the worst outcome, is that, when research was done in ACS patients, most of the initial studies really enrolled a very low percentage of women, maybe less than 20%. So these studies are really not reflective of our general population of ACS. Hence, we don't know in women what are the correct doses of medicines that will cause a mortality benefit. So medicines such as statins, are we giving them the correct dose for antiplatelet, antithrombotic agents? Most of the older trials had a high proportion of men compared to women in the enrollment. Another factor which I think also contributes to outcome is cardiac troponin levels. The troponin levels may vary between men and women. So ACS can again be underdiagnosed in women. I'll give you an example from the United Arab Emirates, where I work. So there was an analysis of a subset of the Gulf Registry of acute coronary events. And they looked at women versus men and the outcome. And really, it showed that women that presented were significantly older, presenting at the age of 64 versus 50 years of age. And that women had generally more than one risk factor. They also found that less often the female would be treated with the appropriate medication. And the adjusted in-hospital mortality in women was almost 5% compared to men, which was 1.2%. This is the in-hospital mortality. Heart failure was also almost double in women compared to men. So how are we going to improve 30-day survival? That's the big question. So these are a few things that I think each hospital or country should work on. And it's really early recognition and diagnosis, optimal reperfusion therapy, risk factor modification, multidisciplinary care, individualized treatment approaches, patient education and follow-up, and quality improvement initiatives. So let's talk about early recognition and diagnosis. So previous trials have suggested that women with ACS present with different symptoms compared to men. However, recent studies have shown that symptoms of women presenting with an ACS may be different, but still there's a significant overlap. So, when I was in med school, we used to think women don't get chest pain. Well, they do. They do get chest pain. And they're having an ACS if they're having chest pain. So women with ACS have higher odds of having pain They can have chest pain or pain between their shoulder blades, nausea or vomiting, and shortness of breath when compared to men. In contrast, women with ACS have lower odds of having chest pain and diaphoresis compared with the men. So they can still have chest pain, but they tend to have more pain between the shoulder blades, nausea, vomiting, and shortness of breath. There is no significant differences in presentation, whether left or right arm pain or shoulder pain between men and women. So we've always said women have atypical symptoms. And like we said, chest pain is still the most common symptom in women diagnosed with ACS. They can have other symptoms like pain between the shoulder blades, nausea, vomiting, shortness of breath, but they tend to also have pain. So typical chest pain is chest pain in the chest, in the arm, or the jaw with heavy tightness, pressure-like squeezing pain. Atypical chest pain, we've always said in the past, it's been epigastric or back pain with a burning sensation. The term atypical is really misused and it implies non-cardiac chest pain. It also leads to stereotypes based on gender, so which may impact risk stratification, contributing to inaccurate triages, resulting in delays and diagnosis of treatment. So in 2021, the ACC, the American College of Cardiology chest pain guidelines discouraged the use of atypical chest pain, as it can be unclear if the term is being used to indicate angina or to describe non-cardiac symptoms. So they've encouraged from 2021 to start using cardiac chest pain versus possible cardiac chest pain or non-cardiac chest pain. And here are their recommendations. So they recommend that we have to focus on the uniqueness of chest pain in women, and that women with chest pain are at risk of being underdiagnosed and undertreated. So a history is recommended along with the symptoms. They've removed atypical chest pain from their guidelines. And like we said, they've advised us using cardiac chest pain, possibly cardiac chest pain or non-cardiac chest pain. So the second things which affects early recognition is the troponin levels. So we talked about the history. Now we're going to talk about the troponin. So some studies have shown that women have a low cardiac troponin level. Factors like age, BMI, and diabetes have been shown to increase cardiac troponin levels in women. Most hospitals use the same troponin cutoff for men and women, but it is important to know that women's troponin levels can be lower at baseline, and to perhaps think about having a sex-specific approach when serial cardiac troponins are being tested. The third thing is also the pathophysiology of ACS in women. So men tend to have more plaque rupture. Women tend to have more plaque erosion. When you do a cardiac cath and a patient has plaque erosion, often that can be missed on an angiogram. So intravascular imaging is really important. If you have a patient where there's no clear SCAD or something else, I think with clear chest pain, and an ACS symptomatology, it's very important to do imaging because there could be plaque erosion and that can be treated. As my colleague just talked about SCAD, it's quite uncommon in ACS populations, but in women, it's very common. It's almost exclusively in women. And you need to have a high suspicion for SCAD in women. So let's talk about the optimal reperfusion therapy. So there was a study from China that enrolled almost 1 million patients, and it looked at women if they were receiving the same evidence-based ACS treatment compared to men. And it showed that women are less likely to receive evidence-based ACS treatment including heparin, dual antiplatelet therapy, reperfusion therapy, and secondary prevention therapy. The proportion of women with ACS who received early dual antiplatelet was 89 versus 93% in men, and reperfusion was almost 9% higher. And again, discharge rates on DAPT were higher in men compared to women, therefore leading to a higher mortality in hospital mortality in women compared to men. There are other studies, and I tried to get studies from all over the world, so we have a global understanding. And it showed, again, in Germany, that women were less likely to have PCR CABG when compared to men. From Switzerland, it showed that, again, same thing, basically. So just a quick word, because I think I'm going to run out of time, about risk factor modification. So when you look at women, really one of their biggest risk factors that can, cause more MIs and infarctions, and it's really important for us to understand, is smoking. So women that smoke have a higher, almost 6-fold increase of events compared to men who smoke. So it's really important to get smoking in the history when you're talking to a woman. It's really the strongest risk factor in middle-aged women. One of the things in this part of the world is smoking is a taboo. So often physicians feel awkward asking female patients if they smoke or they don't. And females often will deny smoking. And I suspect now the rates of smoking are actually going up with the vaping devices on all these devices. So it's really important to get that in the history early on. MDT is really important when we're dealing with women. We have to involve cardiologists, emergency physician, and all allied health teams and nursing. There has to be ongoing collaboration and quality improvement projects to look in women and ACS and their discharge medications. Another thing which I think will help improve the 30-day mortality is really to look at each woman separately, not as a whole, to tailor treatment plans to individual patients. So women tend to be older when they present with their first MI and may have comorbidities that can influence treatment choices. So that's one thing in older women, but also for other women, as healthcare workers, we need to understand that most of these women are also caregivers. They have children, they're juggling 100 things, they have many responsibilities. So they tend not to be as compliant with medications, with follow-up, with cardiac rehab visits. So we need to be more flexible to help them come to their appointments, maybe in person or telemedicine, allow children to come to their cardiac rehab visits, empower women really with their knowledge so you can actively engage them in the recovery process. Sometimes there are a lot of stressful situations that women need counseling for, so also offer them that support. And that really will help adherence and recovery. Also, patient education is really important. So like I said, making sure that there's flexibility in the appointments, emphasize the significance of patient education regarding medications, lifestyle changes, and have a clear communication and adequate patient understanding to enhance adherence to treatment regimens and hopefully improve overall outcomes. So the last thing that I think is really important to improve mortality is to have ongoing public awareness campaigns that need to address women's recognition of symptoms and early action for STEMI. So it's not just the medical professions, but it's also the women, the public. They need to know about ischemic heart disease. It needs to be in their priority list. For us physicians, we need to be aware that there's gender-related differences in door-to-balloon time, and we need to have champion protocols that reduce these discrepancies in STEMI patients. We need to consider gender-specific clinics that are led by experts in the field, like chest pain clinics for women, have continuous quality monitoring and feedback mechanism that can help identify areas of improvement. and also have gender disparities as a performance indicator for the hospitals. So this way people will take more action into making sure that there's some equality. And that's it. Thank you.
Okay, thank you so much. And thank you so much, Dr. Noor, and really enjoy that your comprehensive study. Especially appreciate that you summarize all the topics about the previous speakers talk about. And I think we have 5 minutes to discuss, and I want to address the first questions. I think that's the way that we improve the treatment and the outcomes of the patients, not only in their early diagnosis, but the early interventions optimize the medical therapies. And they point out several important things like the troponin is so different between the men and women. And also the medical therapies, we don't have the optimal dose for the woman. So I think, another thing that I think is quite interesting about the cardiac remodeling, because we have one previous study that we published that's after myocardial infarctions. And I think the woman has a higher probability to have like a myocardial ruptures or like a poor myocardial remodeling and even post-myocardial infarction heart failure. So do you have any comment about the cardiac muscle, the muscles after myocardial infarctions? Is there any kind of difference between the men and the women? Thank you.
Yeah, that's a very good question. I'm sure there's a difference because they do tend to present more with complications and heart failure. But one of the things may also be is that they were presenting late, and that's why they didn't get the appropriate reperfusion therapy. But if there's a specific difference, I'm sure there's something out there that I don't know.
Yeah, I agree. Yeah. So I'm wondering the moderator or the other panelists, they have questions for Dr. Noor? Yes? No? Okay, thank you so much. And because I think the time is limited, so I'm going to close this section. And so I think today we have very nice, and I always enjoy have the participate in the activities raised from APSC, because we can have all the experts from different kind of countries, and then we talk about the latest topics, like especially as a female cardiologist. I really enjoy we talk about the gender difference between the patient who have obstructive, non-obstructive myocardial disease. And I think, but we have difference, but we have the same thing, that we really want to raise their evidence-based clinical practice and how to get a better outcomes to treat our patients in different countries. So I'm going to close sections and really appreciate the first speaker from Thailand, the Dr. Walampomor, and she talked about the risk classifications in patients who have chest discomfort, and we can see that's so different between the men and the women have different kind of strategies and the cardio values if we do the risk assessment. And also the second speaker, Dr. Moji, and from Japan, she talked about the INOCA and the MINOCA. And we got the ideas about the coronary spasm and the coronary microcirculation and how we can measure it during the CAS lab. And the first speaker is Dr. Maria from Philippines, and she talked about another spectrum about the Takotsubo disease. I think this is very important because we have a high probability have Takotsubo in women, but the woman will probably have better outcome compared with men patients. And the fourth speaker is the Dr. Lin Jialing from Taiwan, and she talked about SCADE, that is spontaneous coronary dissection, and which will be possibly healed after 1 month, but we still have paid a lot of attention on that, especially sex hormone can possibly will play a role between the SCADE. And the last speaker is Dr. Noor, and she summarized all the topics that raised by the previous speakers, and because how to improve the outcomes after myocardial infarctions. I think the difference between the men and the women, and also we have to do the early diagnosis, and also we have to treat the patient individually and based on the guideline suggested recommendation. But I think still need a large clinical trials and more experience, and we can know how to treat the patient, especially the woman patient individually. And really appreciate everybody's participation, and hopefully everybody's enjoyed this talk. Okay,
Yeah,
thank you.
I think before we leave the session, we have to take a group photo.
Yes,
Take a photo.
group photo.
Please
Yeah,
open-
most
yeah,
important
open the
thing.
camera.
Okay, great.
Please
So
open the
I
camera.
would like to thank Dr. Julian Lin, to arrange a very exciting topic today. Yeah, thank you
This
so
is
much.
an excellent section, very excellent section. And let's take a photo. Please open your camera and we'll take a photo.
Okay, good.
Timothy, is it okay now?
Yes, done.
Done.
Okay.
Okay.
Okay, thank you very
Thank you
much.
so much.
Thank you.
Thank you,
Thank you.
everybody.
Thank
Yeah,
you.
Look
bye.
forward to seeing everyone.
Okay. Bye bye. Thank
Bye-bye.
you.
Bye.